Surviving all the way to age 100 with a fully intact health span represents the core objective of Medicine 3.0. Modern cardiology follows a central dogma to achieve this, lowering Apolipoprotein B, or ApoB, to extend human life. ApoB is the primary structural protein found on every cholesterol particle capable of causing arterial plaque. Data from the UK Biobank reveals a direct linear relationship between genetically predicted ApoB and mortality. This was established using Mendelian randomization, which is an analytical method using natural genetic variation to determine if a specific risk factor causes a disease. However, observational data from the Amoris cohort suggests a contradiction. Amoris is a 35-year longitudinal study from Sweden, tracking blood biomarkers and their relationship to exceptional longevity. It showed that centenarians often possessed higher total cholesterol from age 65 onward compared to those who died earlier. We are faced with a conflict between lifelong genetic causality and late-life epidemiology. How can the undisputed causal driver of heart disease appear to become a protective force in extreme old age? Conventional cardiology maintains a strict focus on driving lipids to the absolute floor using blunt pharmacological tools. Conversely, many skeptics use centenarian data to argue that higher cholesterol may be a requirement for protecting the aging brain and body. These critics often cite the metabolic side effects of traditional lipid-lowering drugs as proof that the standard medical approach is flawed. Both positions overlook the biological reality of aging. The physiological priorities of the human body shift significantly as we move through different decades of life. Solving this requires us to map exactly how cardiovascular risk transforms between age 40 and age 100. We must look closely at the physical reality of the arterial wall to truly understand why lipids matter. Plaque formation is determined by the total particle count, measured as ApoB, rather than the cholesterol payload contained within those particles. These particles enter the artery through transcytosis, an active transport mechanism carrying them across an intact endothelial barrier via cellular vesicles. This process is concentration dependent. More particles in the blood means a proportional increase in particles trapped behind the arterial lining. Trapped particles eventually oxidize, triggering an immune response that builds the physical atherosclerotic lesion. This lifelong accumulation of trapped particles represents your vascular debt. Because transcytosis is a physical process, ApoB is the causal agent of heart disease. Suppressing it in midlife is a biological requirement for longevity. We have to explain why the rules of heart disease appear to stop applying at age 85. Data from the ASPRI trial shows a U-shaped curve for all-cause mortality in older adults. ASPRI analyzed health patterns in older populations. When we overlay cardiovascular mortality onto that same graph, the line is strictly linear. Cardiovascular death still follows the rules of particle concentration, but all-cause mortality has decoupled from the lipid profile. In extreme old age, competing risks like cancer and frailty overtake heart disease. This creates reversed causality, where a disease changes a biomarker. Here, low cholesterol is a clinical warning siren for malnutrition or systemic decline. The higher cholesterol in centenarians acts as a proxy for physiological resilience, not a shield against heart disease. We must also account for survivor bias. Those most vulnerable to ApoB-driven disease already died in their 60s and are absent from centenarian data. The biological rules of ApoB remain constant, but the meaning of cholesterol changes within a failing body. Forcing ApoB to the absolute floor using blunt pharmacological medication carries severe metabolic costs that are too often ignored by modern medicine. Statins, such as atorvastatin, are the primary tools used to achieve these reductions. A 2024 study reveals a 5-step flow showing how statins disrupt the gut microbiome. They reduce Clostridium bacteria, diminishing UDCA, a bile acid regulating metabolism. This drop causes a 50% suppression of GLP-1, a hormone regulating appetite, leading directly to insulin resistance. This trade-off is particularly relevant for the LMHR phenotype, lean individuals experiencing extreme elevations in LDL cholesterol after adopting a ketogenic diet. Managing these patients requires CCTA imaging to identify soft plaque. CCTA is a non-invasive scan using X-rays to create detailed 3D maps of the heart's arteries. Longevity requires avoiding the trap of fixing a lipid panel while compromising the patient's metabolic health. We need an adaptable clinical roadmap that covers the entire human lifespan. This clinical roadmap must physically tilt between the ages of 75 and 89, a critical period known as the longevity transition. Prior to this transition, the priority is aggressive ApoB reduction to prevent long-term plaque accumulation. After this transition, priorities shift to preserving muscle mass, insulin sensitivity, and cognitive function. Newer precision tools allow us to lower ApoB while minimizing metabolic trade-offs. PCSK9 inhibitors are drugs that increase the liver's ability to clear LDL particles from the blood. Because they are large molecules, they do not cross the blood-brain barrier, protecting cerebral cholesterol synthesis. CETP inhibitors are medications that change how cholesterol is transferred between different types of lipid particles. One agent, obicetrapib, has shown promise in reducing p-tau217. P-tau217 is a specific blood biomarker tracking the early accumulation of Alzheimer's pathology in the brain. We can visualize this strategy through the biological checkbook. Early in life, the goal is minimizing vascular debt by keeping ApoB low. Later, the priority shifts toward resilience, focusing on metabolic and neurological buffers required to survive the final decades. Success is defined by keeping vascular debt low early while maintaining metabolic credit late. Longevity optimization requires moving past binary debates to master shifting biological priorities across the human lifespan.